Hi there. Right, so I think you can hear me. Well, so these are the rates that we've come across, novel metrics for reporting compliance to clinical guidelines. I'm really lucky to be working with a group of really highly qualified and experienced IP optometrists with a plethora of higher qualifications from the college and under the supervision of Dr. Mark Dunn at Aston University. So the first thing that we need to think about is why does measuring compliance to guidelines even matter? Well, guidelines are a distillation of the results of good studies pertaining to the investigation and management of ocular conditions or conditions in general. So they're evidence-based. They're used alongside clinical judgment, but form a really useful scaffolding, particularly for new clinicians or clinicians looking to increase their scope of practice. Following guidelines, therefore, optimises the patient outcomes and minimises inappropriate interclinician referrals, particularly important during the COVID period and the post-COVID period. Therefore, assessing the appropriateness of eye care against guidelines is really, really important for service evaluation. It can, for example, both flag up areas where practice differs greatly from guidelines and monitor the effects of any quality improvements, but it can also be used to demonstrate good practice, which is always a good idea when you're sitting across the table from commissioners and acute trusts. There are lots of studies evaluating the appropriateness of clinician performance, but the reference standards differ across the studies. Some compare current practice to expert opinion. So a patient may be evaluated by an optometrist and then subsequently re-evaluated by a consultant ophthalmologist, and their records are compared for adequacy. Or a group of specialists agree to the tests that need to be undertaken for a given condition. So they identify the quality indicators, and these are then looked for in patient records. Some studies look at recommendations such as NICE guidelines. The NG81, for example, is a famous guideline. It looks at 5 aspects of the patient in order to get to a diagnosis of glaucoma or HT, and that's looking at the optic nerve head, the intraocular pressure, central corneal thickness, visual fields, and gonioscopy. And really what's assessed is how many times these particular quality indicators or these tests are undertaken in the patients that present with suspect glaucoma. So say, for example, 10 patients present with suspect glaucoma and optic nerve head is checked in 8 of them, the compliance then would be 80%. That's actually the naive test rate of that particular indicator. The vast majority of the current studies, though, they consider only one ocular condition or even just a particular test, and they don't consider all the conditions across a service. Is this really evaluating the appropriateness of eye care? Well, in theory, a clinician could sit a patient down for 2.5 hours and conduct absolutely every single test in their armoury, and they'd still be assessed as highly appropriate because these included the required quality indicators. So it's more of a technician role than a clinician role. So the naive test rate, therefore, is flawed and doesn't give the complete picture of the complete examination. Tests that were not undertaken must also be taken into account. And this is particularly important because we have finite resources and an increase in demand in eye care. So what was done? After the study received ethical approval from the Life and Health Science Research Ethics Committee at Aston University, an EPR was designed, an electronic patient record. The EPR was designed for the ongoing study, that is the application of machine learning to the clinical decision making of IP optometrists, and this is the bigger study. The contents of this electronic patient record, you can see it in the background, were extracted from the College Clinical Management Guidelines, the CMGs. Drug options were taken from the BNF and the optometrist formulary, and the design was also informed by the 4 participating IP optometrists. The EPR consisted of 76 quality indicators, you can see them with the boxes, and they covered aspects of history and symptoms in the blue area, the clinical signs in the green area. And these were highly stratified for the purpose of machine learning. 2 diagnosis and management options were given alongside the drug options with complete regimens, so administration and duration for up to 6 drugs. The 74 anterior ocular conditions were extracted from the clinical management guidelines, clearly used as the reference standard. Though manual diagnoses were allowed to be entered as well. The EPR accommodated both positive and negative findings, and any test not selected was deemed as not undertaken. So this EPR was then sent out to the 4 members of the Acute Primary Care Ophthalmology Service, or APCOS. APCOS is a group of IP optometrists accepting referrals from other optometrists, pharmacists, and 62 GP practices. The beauty of this service is that it's completely IP optometrist led and delivered, so independent prescribers have led and delivered this with no consultant oversight. And this has been running in West Kent since 2010, very successfully. The data was collected over a period of a year. 1,351 patient episodes were gathered, of which 822 pertain to the anterior ocular CMG conditions. As you see at the bottom, the red area, an anonymized code was automatically generated by the EPR for secure data transfer between clinics and Aston University. And so this was decoded, the information was decoded to reveal the clinical data on the analysis side. The clinical tests undertaken, management decisions and prescribing decisions of the specialist IPL optoms was compared to the CMG recommendations using the novel metric. So the one at the top is the naive test rates, the number of times a test is carried out over the number of times that the episodes presented. The adherence was calculated using the number of times a recommended test was carried out and the number of times a test that was not recommended was not carried out. Non-adherence was investigated using two metrics, the overperformed rate, so when tests not recommended were undertaken, and the underperformed rate, which was when tests or decisions that were recommended were not undertaken. So these metrics were used to evaluate 5 aspects of clinical examinations. That's history, the symptoms, clinical signs, management decisions and prescribing decisions across the 48 CMG conditions seen during the data collection period. So the overview of the eye care delivery across these 48 CMG conditions was as follows. So first of all, looking at the chart here, the naive test rates are the grey bars. The blue line is the adherence against the CMGs. The orange line is the underperformed rate and the green line is the overperformed rate. The error bars are the upper and lower 95% binomial confidence limits. On average, an element of patient history was reported in 12% of cases, which is surprisingly low. However, when it was asked, these elements were asked in accordance to the CMG listed aspects of history, with a mean adherence of 78.9%. Under and overperformed rates hover at the bottom of the screen, and that's with mean rates of 6.9% and 14.2%. So they were pretty good at doing asking the questions pertinently. The symptoms. Now, the IP optometrists were asked to record the clinical findings of the worst eye or the right eye for bilateral and symmetrical ocular conditions. Laterality was reported in almost all cases, 98.8%. Equally, laterality is mentioned in all the CMGs, and so therefore the adherence for this was high. For symptoms, the IP optometrists were asked to judge whether the patient reported ocular discomfort or visual disturbance as the chief symptom. Ocular discomfort was the most investigated symptom. Adherence for the investigation of the symptom was high, 89.9%, with a low, under and overperformed rates. The visual disturbance showed a low naive test rate. They didn't check for it very much, and that was 22.3%. And about half of these were deemed as appropriate in comparison to the CMGs. So there was an underperformance of this particular mode of questioning for symptoms. Clinical signs. The 66 clinical signs were investigated across the CMG episodes. The naive test rates were highly variable, as you can imagine. It is across 48 conditions and ranged from 0.1% at facial chemical burn all the way up to 63.5% for corneal staining with sodium fluorescein dye, the most conducted test. However, adherence is hovering around the top again. So we know that they were doing it in accordance to the CMGs with low underperformed and overperformed tests. So mean adherence was 93.8%, mean underperformed was 3.4%, and mean overperformed was 2.8%. The two exceptions you can see, there are 2 dips in the clinical signs, and they are at epiphora and conjunctival episcleral hyperemia with an underperformance of these particular tests. Now we'll come to that a little bit later on. The management decisions. Now, on the outset, when you look at this graph, it's sort of shock, horror. Why is there a dip here for the adherence when it comes to routine referrals? Now, we must remember that this is a tier 2 community service, which is designed to assess and manage patients in the community as opposed to sending to the hospital service. So we wanted, this service is intended to reduce those referrals to the hospital. And this shows actually that there is an underperformance of routine referrals to the hospital, where the adherence goes dips, and so really what it shows is that the service is successful at what it's intended to do. The most favoured management options were follow-up and discharge, and really interestingly, 97.4% of patients were managed in the community at the first instance, which it can't be bad. Prescribing decisions. So like mandatory decisions, the CMGs recommended multiple therapeutic options for ocular conditions depending on the severity of the condition. The adherence for prescribing decisions, the drug type prescribed, so you can see them all here, made by the IP optometrists were high. So the mean adherence was 93.6%. The mean overperformed rate was 0.9% and the mean underperformed rate was 5.6%. And you can see from the chart that that really only applies to ocular lubrication. As an IP optometrist myself, we're not really recommended to give ocular lubrication on a prescription. The patient should be advised to buy them themselves, and that's because it becomes vastly expensive. The metrics, therefore, have demonstrated that over 48 CMGs, we can look at an overall view of the service delivery and see how well we're doing in comparison to the guidelines. But the metrics can also be used to evaluate the performance of individual clinicians or even individual ocular conditions. And this can highlight small but important areas of guidelines non-adherence. And this is especially important for rarer conditions and those that show a stark contrast to the guidelines, such as preseptal cellulitis. Now, before we go into this chart, there were only 10 episodes of preseptal cellulitis, a rare condition, presenting during the data collection period. That's out of 822. But it's interesting to look at how this shows us what's going on. For the management decisions, preseptal cellulitis showed that the adherence plummets to 0 for rapid access and follow-up. Now, the CMG for preseptal cellulitis shows that these patients should be sent to the hospital without intervention. Clearly, this isn't what's happening. 100% of the patients, so there's an overperformance of 100% here, they were followed up within the community service, and 100% underperformance of rapid access. So what's being done with them in the community? Well, if we look at the prescribing, we can see that from the chart that the naive prescribing rate, the adherence and the non-adherence together show that the patients are being given systemic antibiotics in the community contrary to CMG advice. This is particularly interesting because not only can these metrics then be used to measure compliance to guidelines, but they can also be used to inform a reference standard of changing practice patterns, which is particularly important in a fast evolving profession such as optometry and in the current time. IP optometrist behaviours should really be used to inform guidelines and research as much as the guidelines are used and should be used to inform best clinical practice. So in conclusion, the evaluation of the appropriateness of eye care lacks a standardised reporting method. We suggest that the appropriateness of eye care can be investigated by measuring compliance to evidence-based guidelines. And for IPs, that really should be the College of Optometrists CMG.